he explained a lot of my research. So let's go to the case. I am designated to present this as for this patient for conservative treatment. So please raise your hand who is with me that this patient should be treated conservatively. No? No one? Just one of my friends, yeah. But I agree. This 43-year-old male with neuritic grade 1 and JOA score 15, it's equivocal. I might have taken this patient to surgery for probably posterior laminoplasty or laminectomy and fusion. But if we change the theme a little bit, if he is neuritic grade 0 and JOA 16, I would definitely go for conservative management. Let's look into the neuritic grade 1. What is neuritic grade 1? Neuritic grade 1 means signs of core compression, normal gait. So there is signs of myelopathy. And JOA score, a normal JOA score total is 17. So 15 means at least two of these four are present. Discrete weakness in hands or proximal arm. Able to walk without walking aid, but inadequate or slowly. Or minimal sensory loss. This one might be relatively minor. And last one, mild bladder dysfunction. So 2 of these 4 is quite significant in my mind. But if only one, that I think we have good reason to argue for conservative treatment. Because when we considering surgery, we are always balancing between risks and benefits, right? So we look at the complication rates into this surgery. Here's a series that we published 2 years ago in our group. Basically we did this kind of surgery. It's anterior and posterior. We did a posterior laminectomy and fusion for decompression, and then the anterior decompression for the most stenotic segments of the OPLL. And if you look into the perioperative characteristics of these patients, the JOA scores were 12, mean JOA 12. So these patients are a little bit more severe than the example case. And post-op JOA score improved to 14. But if you look into the complications, there are lots of complications. C5 palsy, 12. Even bilateral C5 palsies, transient hoarseness, dysphagia, wound infection, CSF leakage, 13 patients. So a total of 41 patients follow up for more than 2 years. And there are majority of them, nearly half of them are the most common continuous type, like the example case. Segmental type, about a quarter. Mixed type, another quarter. And localized type, only 7%. These are all long segment, severe OPLL causing myelopathy. Unfortunately, myelopathy and all other functional outcomes improve significantly at 2 years post-op. And however, there are 13, that is nearly 1/3 of these patients had intraoperative CSF leakage. And if you do a subgroup analysis of this intraoperative leakage and those without intraoperative leakage, the demographics or clinical outcomes were pretty similar. They're pretty much the same. So in conclusion, the paper concluded that at 2 years post-op, there were no differences in the demographics, functional outcomes, and complication rates between the CSF leakage and the no leakage groups. And the CSF leakage group had more patients with continuous type OPLL than the no leakage group, with 77% versus 29% only. Here's another example case, which I did a couple of months ago. It's a 63-year-old female, neuritic grade 1, JOA 15. So the neurological function is very similar to what we had in this example case. And this is a short segment OPLL. And what I did is I did a corpectomy and the ACDF, take out the segment. Unfortunately, the patient neurologically improved. She's about JOA 16 right after surgery. However, we developed this nasty pseudomeningocele because of an intraoperative CSF leakage, which is very difficult to manage. This is another study. A long-term study demonstrated that JOA score greater than 14 for asymptomatic patients that underwent non-surgical treatment. These patients can get satisfactory outcomes by non-surgical treatment, such as reducing neck movements. Another paper published in Journal of Neurosurgery Spine 10 years ago, they look at this kind of OPLL causing myelopathy and treated with conservative treatment management or surgery. See, these patients improved from JOA 15 to 16 in a period of time of 2 to 3 years. And more importantly, only one patient, that is less than 5%, 1 out of 21 patients actually had worsened neurological function during the follow-up. So these patients can be managed conservatively initially, at least for a period of time. So neurologically, patients who maintain a JOA score of 15 or higher can essentially be treated conservatively. Many spine surgeons thus consider a JOA score of around 12 to 13 to be the cutoff point indicating the option of surgery. And many asymptomatic patients with OPLL do not develop neurological symptoms. The possibility of symptoms deterioration is low in the absence of myelopathy at first visit. In contrast, if myelopathy is already present, the risk of symptom deterioration is high and the surgical treatment may be effective. So I think the issue is if we can do surgery, if the complication rate is low, then we can manage these patients surgically. However, if the neurological function is still very good, the chance of neurological improvement is slim. So in these patients, we should consider conservative treatment first, at least for a period of time. Thank you very much.